Hello, and today we're in clinic with Emily, and this case is going to be an interesting one as we've got a two-part case where first of all we're going to assess, make a treatment plan, and then remove some unwanted filler, and then in the second session we're going to look at a treatment plan targeting multiple facial zones. So let's get started first of all by introducing Emily, our patient.
Hi.
Thank you for joining us today. Maybe the best place to start is if you could just imagine that we were in the clinic together, just me and you. What would be your objectives for having any treatment?
So my overall objective is just to look naturally reasonably younger, to target some sagging around here, some loss of volume around here, and generally just fine lines around the mouth and around the eyes. Perfect.
We've done all the medical history, we've done all the consent process, we've taken some photos, you can see a before and after our case. So our patient is asking us for a general rejuvenation, general restoration type treatments. So that gives us an open canvas for thinking about which treatments we can look at, and more importantly in this case, maybe how we could sequence it, given that we've had maybe up to 10 years of treatments in the past. And often what we see is that patients over time will notice that they don't seem to change so much, but the treatments they have changed, and filler that can accumulate over the years can often create unwanted distortions that are sometimes hard to perceive as the patient. And so our job as clinicians is then to try and identify where we think maybe potentially filler has displaced over time. And there are a few key areas which are quite prone to this. So this case will be quite good at looking into how we can address that, almost starting afresh so we can then build on a new treatment plan.
Sorry to interrupt this video. Hi, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I'm the one doing the injection that you're watching right now. I just want to take a moment to talk about our injectables diploma. So Harley Academy is a higher education college for aesthetic medicine based out of the centre of London, UK. And over 3,000 medical professionals have gone through our academic programs to achieve a postgraduate diploma in aesthetics. They will get a title after their name, PG Dip Aesthetics. If you want to learn more about our programs, how you can gain your qualification and learn how to inject in a really structured, systematic and evidence-based way, then click on the details below and our team will be happy to have a conversation with you. Right, that's enough from me. Let's get back to the video. But if you are enjoying this and you want to see more content like this, please subscribe and click like.
So Emily has just told me that she has turned 53 recently, and I would personally say that Emily looks well for her age. And this is obviously, I think, because she's been having treatments over the years, but also fundamentally, Emily has good features, good bone structure. And there is a systematic way in which we can look at the face. And I'm going to start going into more detail on this in her second treatment when we actually outline a treatment plan. The thing that I want to call out for today's session is where we think there has been elements of displacement of filler over the years. And there's three characteristic areas that I'm going to be running through today. So the first one is if we start with the highly mobile zones of the face. And these zones are the orbicularis oculi muscle and the orbicularis oris muscle. And the orbicularis oculi muscle is the most active zone of the face, and it's because we are blinking and moving our eyes so many times throughout the day. The orbicularis oris is second to that, where we have an enormous amount of movement. The lips are extremely dynamic, and so because of all this movement, these two zones are prone for filler displacement over time. But that's not to say that it will just happen automatically. There are things that we can do as injectors and things that we shouldn't do as injectors that assure us that our patients are unlikely to have filler migration or filler displacement over time. So I want to talk about three different factors, but before I do that, let's just see if you can see what I see from a lateral view. You can see here in the upper lip that the filler has moved beyond the vermilion border, and we have a little bit of a ridge coming across the upper lip like this. And on frontal view, often this looks like increased height. And when patients look in the mirror, perhaps they don't see this, but when we're assessing our patients in clinic, it's really important to also see them from the lateral view. And for me, this is very subtle, okay? I don't think that many patients would even notice this, but what we can see as injectors is the consequence of repeated treatments, the consequence of incorrectly identifying the lip compartments or using the wrong products, and that will then ultimately lead to migration of product or displacement. So that's characteristic in the upper lip. So now let's move to the under eye zone. And one of the other characteristic areas where we get chronic displacement of filler is the tear trough. And there are multiple reasons why this happens. The actual under eye itself can be prone to the same mechanical consequences that happen around the lips, i.e. the orbicularis oculis moving so much that there's a natural scrunching motion of the orbicularis oculi contracting, and any gels around the under eyes are subject to mechanical stress, which will slowly collate the gels into this nasojugal area, okay? So the filler is constantly being moved in this circular direction, clockwise towards the medial aspect of the under eye. So that's happening biomechanically anyway. But let's talk about the things that we can do both in the lip and the under eye that reduce the risk of this form of chronic displacement, okay? So first of all, number one is product selection. Generally, we know that higher G' products actually are more likely to stay in the compartments they're injected. And this is a little bit at odds with what the kind of products that we would want to naturally feel in the tissues, particularly in these soft zones like the under eye and the lips. So it's worth mentioning that there is a little bit of a balance here between the kind of gels that you would want to feel in those tissues versus the kind of gels that would actually stay put over time. So that's number one. Number two is respecting the anatomy. And we know in the lips, for example, that there are 12 anterior and 12 posterior compartments. And we also have a structure around the outside of the lip known as the vermilion border or white roll. And so understanding those compartments and the anatomy and then injecting in a way that doesn't allow for filler to move beyond those compartments is going to be critical to ensuring we don't have this displacement. Likewise, in the under eye region, injecting underneath the orbicularis oculi muscle rather than above the orbicularis oculi muscle means it's less likely to move over time. The third thing is avoiding undue trauma. So if we have these structures and we're injecting into them in the right way, we also want to inject them in a way that doesn't unnecessarily traumatize or put the filler at risk of moving into the wrong places, whether it's distorting the vermilion border or whether it's actually injecting above the muscle. And the final point is to avoid overfilling. So if we're injecting into these compartments, if we inject too much volume, then naturally those compartments aren't going to contain all the product in the lip, in the example of the lips, or in the under eye, injecting so much volume underneath the muscle that it naturally has nowhere else to go but above the muscle. So overfilling is another risk factor for avoiding these signs of chronic displacement. So in Emily's case, as we see in many patients who have had filler over the years, we have these characteristic signs, and I'm hopeful that with some hyaluronidase today, we can reduce the appearance of the unwanted filler. The second area that I want to treat with hyaluronidase is the medial cheek. And this is I would say, the most frequently overfilled zone of the face, particularly with patients that have had filler over time. And one thing to understand here is that the muscle, the zygomaticus major muscle, which originates from the zygomatic arch down to the modiolus of the mouth, this muscle actually acts as a septum that goes all the way from the skin down to the bone. And in doing so, it actually creates a lateral boundary for the filler. And biomechanically, when the patient smiles and this muscle contracts, it will bunch filler medially, and so it will create anterior projection in this part of the cheek. And so this is something that's been recently described as the transverse facial septum. And we have to be very careful in this medial cheek compartment to avoid overfilling, because at rest, things can look beautiful and treated and harmonious, but upon smiling, we can create too much anterior projection, which starts to look unnatural. So if you give me a really big smile and turn this way, what we can appreciate here, I think, is that there is some deep volume that is bunching up on smiling. And when we have too much projection in this area, it can start to look unnatural. It can narrow the gap between the lid-cheek junction, and the anterior projection can be quite significant, particularly in relation to a maxilla that's naturally receding with the aging process. And so we get these quite dramatic contours throughout the face, which in combination with a little bit of displacement of filler under the eye is really what we should be picking up as injectors. It's something that we would like to naturalize. So my treatment plan is a multi-stage treatment plan, but today's focus is to reset back to baseline by focusing on these commonly mistreated areas to avoid filler displacement. What we're going to do first is we're going to use an ultrasound to see if we can visualize some of the deep volume in the medial cheek.
Hi, my name is Max Greenfield. I'm one of the doctors here at Harley Academy, and I'm going to be doing a little bit of ultrasound now just on this medial part of the cheek to see if we can see any of that old filler there. It's sometimes a little bit more challenging when it's been placed a little while ago, and Emily, it's been a little while since your cheek filler, I think.
I think it was somewhere between 8 and 10 years when it's first done.
Fine, okay. Well, we'll have a look and see if there's anything we can see and target. So we're going to start over the medial cheek here. There we go. And what we can see just on this side here is the zygoma. So we've got the dermis, we've got our subcutaneous fat underneath there. We can just about make out the SMAS on the screen here. We'll have our deep fat and then our bone, which is that bright white structure there. And this is our lateral zygoma here. And as we come medially, we can just see it dropping off the medial zygoma towards the apex of the cheek, towards our deep fat compartments. Heading right down towards the piriform fossa on the left-hand aspect of this screen. And whether or not it shows up clearly in this camera, you can just see these little white black circles. That there is filler that's sitting probably a little bit more superficially than we would like for a deep fat compartment treatment. And this could either be sitting in the SMAS itself or in that space between the SMAS and the lip elevator muscles, that pre-maxillary space. But what I can't see is a huge amount of filler down here in the true deep medial cheek fat. So all sitting a little bit more superficially than we would like, which probably explains why it's bunching up a bit during animation. We'll have a look on the other side as well.
So what do you think, Max? Would we dissolve this by treating with a cannula or with a needle?
I think cannula again, between, so popping underneath SMAS, but still staying in that pre-maxillary space.
Mm-hmm. Sounds good.
So let's have a look on this side as well. Let me just unfreeze that. Oh, and again, straight away. So let me start the zygoma so we can find where we are. So again, you can see this white structure under here. That's our zygoma. And you can see actually some filler over the lateral zygoma. So we've got our skin, dermis, subcutaneous fat. Here, this black structure is our filler. Then we've got our pre-periosteal fat and periosteum, this bright white structure. And as I come medially, here, this black structure here will be our orbicularis oculi muscle. Then as I come more medial still, towards the deep medial cheek fat compartment, these little circles, black circles there, that is all of our filler sitting within the SMAS.
Yeah, I think we'd say is that within layer 3?
I think it may well be, yeah.
Which is actually quite common for mid-face treatments, as we are learning on these ultrasound studies, that filler, unfortunately, is actually quite hard to place in the area that you intend it to. And there are various things we can do as injectors to make sure that the filler does end up in the target that we intend. But this is a good example of having multiple nodules of hyaluronic acid actually found within layer 3.
Mm. Very good. Brilliant. So yeah, as we suspected, where it is. Ah.
Thanks, Max. So where does that leave us? What we've seen here is not an unusual thing. And I think that's really important to appreciate, is that there are thousands, possibly millions of patients out there in the world who have had filler injected. Both the patient and the practitioner have intended it to stay in one place, but either at the moment it's injected, it is displaced, or over time it is displaced. And so I think it will become more common and more regular for patients to come into clinics and be completely naturalized back to baseline. And I think this just reflects a lot of the learnings we've had as clinicians over the years. And I think as fillers, the new generation of injecting, the products we use, how we think about injecting will be far more specific, far more scientific, far more anatomical. And I think this is a reflection of how injections have been done over the last decade. The filler that Max has shown you exists actually in layer 3 and layer 4 of the midface. There is very little filler deep down onto bone, which means that if we try to dissolve that filler with a hyaluronidase deep down onto bone, we may actually miss it. The best way to treat and dissolve this unwanted filler in the midface is actually with a cannula. And so we're gonna do that. The specific anatomy of the compartments that we want to treat with retreat, we will cover in the next session. But for today, let's get on with dissolving some of that filler. The hyaluronidase we're going to use, the dilution we're going to use is a 1,500 unit vial divided by or diluted into a 5 ml solution of saline. We can also add a little bit of lidocaine in there. It could be 1 ml of lidocaine and 4 ml of bacteriostatic saline. And so that will give us a solution of the hyalase. And then we're going to use 1 ml of volume to dissolve roughly 1 ml of filler. So let's imagine that we're treating the lips. I'm going to use 1 ml of solution, that's 300 units of hyaluronidase. I'm going to use that around the mouth. I'm going to use the same again under the eyes, and then I'm going to use the same again in the anterior cheek. And so this will give us enough dilution. The saline itself is required to dilute the hyaluronic acid that's in the tissue, with of course the enzyme that's in there to actually break down the hyaluronic acid as well. Here we have our 1 ml solution of hyaluronidase, which is 300 units, and I'm going to be dividing this into each of the 4 lip quadrants, because I'm going to be injecting where the filler is naturally injected into the lip body, but I'm also going to be treating above the border where we think the filler has displaced, and also in the lower lip where I suspect there's a little bit of displacement in the lower lip as well. I'm using a invisible needle with TSK, and we're just going to start with a few injections. Focusing now on the white part of the lip.
Can you feel the resistance of the filler as you're injecting?
I can, yeah, I can feel it in the upper lip in particular. If we inject here and I go through the skin, I can feel that this isn't completely mobile and smooth.
Mm-hmm.
This is what we call a serial puncture technique. Lots of injections of hyaluronidase to cover a large area. Perfect. Now let's move to the anterior cheek, or the medial cheek. And I'm using a 50mm cannula, 25 gauge. This is sufficient to move through the deeper tissues of the midface, and I can also use the same entry point to treat the under eye with this cannula as well. So my entry point is generally going to be at this intersection between the subnasal line and the lateral canthus. It's a very good entry point generally for the medial cheek. And I'm just going to put my entry point through the dermis. I don't need to go any deeper than that. And I like to just give it 3 seconds to make sure there's no flashback. And then I'm going to use 1 entire mil, 300 units in the anterior cheek. And then I'm going to use 1/2 mil for each under eye. As Max showed on the ultrasound scan, we know roughly where the filler is, so we're not intending to treat in this subcutaneous plane, although I may do a little bit. What I really want to treat is layer 3 itself, and I'm pushing down on that now. You can see that tethering here. The filler is entrapped within layer 3 and also just beneath layer 3, but very little product is deep down onto bone in the deep compartments. And so this mid-depth is where I want to be injecting. So if I first of all push through layer 3, we'll find some resistance. There. This is now exactly where Max identified where the filler was. And I'm going to move through, fanning into this area with threads of hyaluronidase.
And I suppose the great thing about hyaluronidase is that it spreads as well. So even if you're not exactly in one of those little filler lumps, then it will be able to make its way into that whole area.
Using my non-dominant hand here to try and create some stability for the cannula. As I move now just a little bit deeper in the medial cheek. So I've treated within and now underneath layer 3. And then I'm just going to spend a tiny bit of product in the superficial compartment as well, for good measure. So that's an entire 300 units injected into the medial cheek. And we're now going to use this same entry point to treat any migrated or displaced filler under the eye. For this one, if you could open your eye for me, Emily. Let's go again. As we approach the anterior aspect of the midface, we want to be underneath orbicularis oculi muscle. That's this depth here. And I'm gently going to fan in 0.3 mils in the suborbicularis plane. You can see the depth of my cannula here. And then I'll do 0.2 mils in the subcutaneous or subdermal plane. Perfect. Let's treat the other side now. So Max, what do you think the main mistakes injectors make when they're injecting and trying to, what can injectors do to prevent filler from going into the wrong compartments when they're injecting?
So in an ideal world, every injection you would do would be under ultrasound guidance. That just isn't possible. So technically, with time, certainly within when you're getting started in a training environment, you've got enough to think about. But I think having simple ways of knowing what layer and what depth you're in is really useful. So particularly when you're using a 22 gauge cannula, when you're subcutaneous and you lift up, you can really see the outlines of the cannula. Even now, you can see just the tip of it there. And being able to differentiate between that and being in a deeper compartment where you're moving freely and you feel that slight give after the resistance before going underneath that layer 3 or in the midface, the SMAS, knowing what that feels like is key to being in the right layer. Have you got any tips for it?
I think that's absolutely right in terms of identifying the compartments and understanding depth control. There's also things we can talk about, in terms of product selection. And if we're using a needle, we can talk about the angulation of our injection and also the bevel of the needle. And these are all concepts that we explore in our GEM framework to give people a bit more standardized structure for how to inject. Last one now, if you look upwards for us, Emily.
Aside from the dissolving, this is a really good example of how you can actually treat or target lots of different areas from a single entry point, because from here, you could get into the deep fat compartment, you could get into the deep piriform space, you could even treat the preauricular and zygoma from here too. So
yeah,
these
absolutely
cannula treatments
agreed.
are really powerful from that perspective.
The one thing is I want to just help to demystify in this is the difference between edema and overfilling. And I think this is often where we get a lot of confusion. So I would not call this malar edema. This here is the consequence of hyaluronic acid moving closer to the surface of the skin from where it was originally intended to be injected, and that attracting water and causing some puffiness under the eye. That's a separate thing entirely from a condition of lymphatic insufficiency which will cause malar edema, which is oftenly presented here. But the overlap is that sometimes tear trough filler can precipitate malar edema. And so that's a complicated concept that we can talk about in more detail, but I often see injectors calling stuff like this malar edema, when actually it's actually the natural consequence of having something so hydrophilic sitting so close to the surface of the skin. So this is what our patient will look like after, if you just sit forward and into the camera, after the hyaluronidase. Okay, so you can see there's a little bit of inflammation, and that's because we do have a very reactive product in the tissues now, which is hyaluronidase. This is a very mild reaction, and you wouldn't be surprised if your patients had a bit more swelling with hyaluronidase, which we've seen many times. And if there is too much erythema and edema associated with the hyaluronidase, then an antihistamine can be helpful to reduce those symptoms on the first day. But what we will notice is this will very quickly settle, and by tomorrow morning, your patient will wake up, or Emily will wake up and notice that the areas that we have treated with hyaluronidase are now significantly dissolved and deflated. I'm excited to come back in a few weeks' time and we can continue the treatment plan. Does that sound good?
Yes, thank you.
All right, thanks very much, Emily. Emily, welcome back.
Thank you.
Welcome back to the clinic. So how long has it been since we did the dissolving?
I think it's 3 weeks.
3 weeks. Obviously, you've noticed some changes. So what would
Absolutely.
how would you describe those? What would you describe?
I think it's quite significant. Loss of volume here, around the lips, to an extent that, I mean, there wasn't a huge amount, but a little bit in the tear troughs. And I think just the whole sense of slightly collapsing.
Yes, and that's not a familiar thing after having fillers for, let's say, 10
No,
years.
and I'm not happy. I don't like what I look like.
So, and I think this is the teaching point, is that we have got to a stage in our field where patients have been having fillers for 10, even 20 years, and that their perception has drifted, and the filler over time has accumulated in often the wrong areas. And so having a bit of a reset like this, I think, is going to become more and more common in what we do in practice. I think the ultrasound study has been particularly helpful in demonstrating where the filler was, and showing last session that the filler wasn't in the deep fat compartments or onto bone, which is what we wanted, but it was actually within the layer 3, the connective tissue of the face, or it was actually just underneath the skin. And so the opportunity to dissolve all of that, as well as the under eyes and as well as the lip filler, start again. Your patient has to be quite brave, so well done. And that's quite a lot to go through, because ultimately there is going to be a dramatic change to how you look.
Yeah.
But to have a clean slate and to build back up from then, I think is really valuable. So thank you for going through that.
No problem.
Is there anything you want to share, I suppose, to anyone who might be also in your position that is thinking about getting this done? I mean, did anyone notice, I suppose? Did anyone notice when you had the...
Do you know what? More people than I think normally would say, oh, are you all right? You look a bit tired or whatever. I think I was probably, which is always true, I think you're probably more conscious of it than anyone else. But I think people did notice, yeah.
You probably can tell, yeah.
Yeah,
Okay.
yeah. It's quite dramatic, I think.
Yes, it is. But hopefully they will also notice when you get back to...
Hopefully, yeah, absolutely, yeah.
Lovely. So let's talk through the treatment plan today. Then we'll go through them in sequence. So the first thing I'm going to do is just do an overall facial assessment again, now that we have dissolved all the product. Let's take this from the top. So Emily had filler previously significantly in the midface, under the eyes and the lips. And all three of those areas have been dissolved. The first thing that we notice, if you turn slightly this way, is we've noticed now the volume loss, particularly in the midface. Turn this way. You can see this, I think, slightly more on this side, and a lot of the filler was actually adding the structure and the volume to the midface. But the way I would describe how it was treated previously is that it was done in a very kind of generic fashion, meaning that this entire area was volumized without much appreciation of the nuances of the structures, the anatomy, the type of product we want to use, and particularly thinking about animation. And so if you give us a really big smile, you can see that Emily naturally has quite good volume on expression. And so this is something you have to understand before carrying out a treatment plan, is to understand what's going to happen when the patient has conversations, when they're smiling. And what I described last time in the video was this line of ligaments that is really important, and it traverses down the midface, separates the midface into the medial and the lateral midface. And we also then have the transverse facial septum of the zygomaticus major muscle. And so if you give us a big smile, all of this volume compartmentalizes medially and projects forwards. And so we have to be mindful of these structures when we're treating. And so when I'm going to do my treatment plan today, I'm going to be focused on how we can treat a mid-face like this whilst always making it look natural, particularly on expression. We also dissolved the under eye area, and we can see that that has returned. There's some shadow under the eye. It's not actually a very significant tear trough, and so I can appreciate how that could be easily overfilled and overtreated. That needs a very subtle treatment. And then, of course, the lips. The lips have been dissolved, and if you blow a kiss for us like this, often when you lose the volume that's been in the lips, we get an increase to the perioral lines. So we'll look at how we can address the perioral structures with a treatment plan today. Okay, so if you just sit forwards one last time, and I'm just going to clean again, and I'll talk through how we would just assess the face naturally without thinking about any treatments. What would our facial assessment say? So Emily's main concern is laxity in the lower face. That was actually the reason she came to book in with us. What we've ended up doing, of course, is doing this entire reset. But if you just support again for us, how do we actually create lifting along the lower face? Well, we have to think about our principles. So first of all, we want to work from the top down. We want to work from lateral to medial, and we want to work from deep to superficial. And so following those principles, we're not going to start treating the jawline or the lips on the first treatment. We're going to start off in the upper face, then the mid face, then the lower face. We're going to start by creating lateral treatments and then more medial treatments. And then we're also going to focus on the deeper targets before the more subcutaneous targets. And so those are the principles that I'm going to follow as we progress our treatment plan. One thing just to always mention when we're assessing the faces for symmetry, and what I noticed is there is a little bit more volume loss on this side compared to this side, so we will have to probably use a little bit more volume here than on the other side. I noticed that the brow is a little lower on this side than this side. I'm going to treat the area above the eye, this area, this supraorbital area, which I think will be a very powerful treatment for today because we lose volume in the deep fat above the eye. And by treating this A-frame, we're going to be able to lower this shadow above the eye, and that can be a very rejuvenated treatment as well. So in summary, following my principles, I'm going to start with the mid-face, beginning laterally, working medially, deep to superficial. I'll then treat the supraorbital and the infraorbital area, and then I'll move to the perioral zone as well. We should be using 5+ syringes of filler, all strategically in the right zones to avoid any additional overfilling or product displacing into the wrong zones. The first thing though is I'd like to see where the filler is now, if there's any left, and with an ultrasound look at where the tissues are before we treat. So rest your head back and let's have a look at those.
We're going to be scanning from lateral to medial. What we can see here is this dark layer at the top is our jelly. We've got our skin, subcutaneous fat, our SMAS layer, that fibrous layer, and then this hyperechoic white structure there is our zygoma, or our periosteum. So we can already see that there's significantly less filler here than there was last time. What we expect the filler to look like are these hypoechoic or anechoic structures, these black circles. And as I'm coming medially, if you remember last time, there were lots and lots sitting within this SMAS layer, more superficial than we would like. We can still see that there is a little bit sitting more deeply down here towards the deep piriform space, but that's exactly where we want it to be, not sitting superficially up here within the SMAS. What we can also see here, if I just lighten my pressure slightly, is this anechoic structure here, which is our facial artery. And it's compressible when I press down, and if I just angle slightly, there we go, we can see the flow in that vessel there. And that's probably sitting a little bit deeper than we expect. At this layer, at this point in the face, we expect it to be running in layer 2.
Now let's look at the midface and the targets that we want to treat with filler. So first of all, let's just remind ourselves about this important division between the lateral and the medial midface. So this, connecting these three dots, is what's going to be dividing our medial and lateral midface. And as a reminder, the lateral midface is passive, and with aging, the tissues can move inferiorly to create laxity along the jawline, whereas medially, because of the structures that pass through from bone all the way through to skin, for example, the zygomaticus major or the LAO muscle, we have lots of structures transecting the layers. And so instead of sagginess, what we see in the medial cheek is more like volume loss. So that's how we get a difference in aging between these two, but either side of this line. The second thing is that we know that if we add volume laterally first, we need less volume medially second. And that's why it's a mistake to start to add volume here first before we've adequately volumized the lateral structures. It's been described that this part of the face is organized like layers of an onion, concentric layers where we can reposition tissues, whereas the medial cheek is more like roof tiles where the tissues are in a and they're not in a concentric layer, but on top of each other with tissues, with structures transecting the layers. And so we have a lot more stability in the medial midface. So my treatment plan today is going to start with the lateral midface. And first of all, I'm always going to want to identify the boundaries of the zygomatic arch. And we can follow the cheekbone like this. Kind of goes like this. Once I'm happy I've found the zygomatic arch, I know the natural direction the cheekbone is going, and so I have the angle of my cheekbone. So that's really important. The second thing we need to do is understand where the apex of the cheek is, the most projected part, which is not an anatomical structure, it's more of an aesthetic structure. And a good way to identify that is to find this midpoint between the zygomatic bone, the midpoint between the orbital bone laterally and this vertical line downwards. That we've already got this. We'll find a nice prominent aspect that we want to create some projection at. So this was where I would say the cheek apex is. And what we can already see is because we've got actually very beautiful natural cheekbones and we've got some volume loss medial to this, this is already well projected. That doesn't mean to say that we shouldn't add a bit more structure, and we're doing that deliberately in order to actually follow our treatment plan principles and make sure that we're not overfilling medially. So I do think we need to add some volume to the apex of the cheek, and then we're going to use a cannula to taper off the zygomatic bone laterally. All of that isn't to try and create lots of projection laterally, because she does have very good, beautiful, defined cheekbones, but it's to start to add this structure, which is going to be important if we're going to try and get the best results in the medial cheek. So this target here is actually our suborbicularis oculi fat, and this target laterally is going deep into our pre-periosteal fat along the zygomatic bone. So this is number one, the apex of the cheek, and number two is the lateral zygomatic arch. Treatment number three is going to be the area behind the line of ligaments underneath the zygomatic bone. This is our preauricular area. We have kind of preauricular, subzygomatic, submalar, if you divided this area into three sections. And all of this can be volumized with hyaluronic acid in layer 2. This is what's going to give a lot of this lovely definition and also tension laterally to the line of ligaments that's going to improve the jawline and the midface. So the treatment sequence number one is going to be the lateral midface, which is going to be the apex of the cheek, the lateral zygoma, and what we would call collectively in this area as the preauricular and subzygomatic and submalar region. So let's do that treatment first. I'm going to just talk about the technique first. So this one will respond very well to a cannula treatment. And I'm going to show you how we use a cannula to treat the apex and the lateral zygoma from a singular entry point, which will be from around here. Remembering that in this part of the face, we can treat in the SUF or we can treat in the pre-periosteal fat. In this case, I'm actually interested in as much structure as possible. So I'm going to be treating in the deepest plane, which is the pre-periosteal fat, which is actually a structure that lives even deeper than the SUF. Okay, so let's make our entry point for the lateral zygoma first. Little scratch. So I'm using a 22 gauge cannula, and I'm just going through the dermis with the needle. And then let's talk about the layers that we need to move through. So if we go into the subcutaneous plane, we need to move underneath the orbicularis oculi muscle. So this is that tethering and dimpling there. So there's a little pop. There. So now I'm in the SUF. This is the suborbicularis oculi fat. The thing I want injectors to appreciate is that we can also go a layer deeper than this. There is another fascial plane, and then there is a fat pad called the pre-periosteal fat. And that is actually what I'm going to add volume in today, because I'm trying to create as much deep structure as possible. So if I go even deeper, there's a second pop. And that is now me gliding truly down onto bone. This is where I'm going to add some projection at the apex of the cheek, where I want the maximal light reflex. Once I've done this, that's about 0.3 mils of Rejuvenation contour. I'm now going to move back into my subcutaneous plane like this, and then move along the zygomatic arch itself. I don't need to be deep yet. I don't need to start treating the deep plane until I get to this point, where I'm going to again perforate through the orbicularis oculi muscle, and now I'm moving in the deep plane along the lateral zygoma, the zygomatic arch. The reason I'm choosing this deeper depth is because, again, this is about deep volumizing, and I want to create as much structure as possible so that it enhances my medial midface treatment. Just trying to create as much of a smooth transition here from the lateral zygomatic arch through to this apex that I've created at the cheek. And that's half of the syringe of filler used for that treatment. So we can just take a look now. Really important that we don't flatten this gel. So we've created a really nice deliberate shape now, and if I use my thumb to press, then I'm going to spoil that. So I can use my finger to roll like this, and that's going to be a nice way to create some definition. But otherwise, we have a nicely defined apex of the cheek and some lateral projection. Let's have a look if you sit forwards. So we can start to see some very nice shape on that cheekbone compared to the shape of this one. We're a little bit more angulated, a little bit more projected and defined. Okay, so now we're going to work on that. But the next thing we're going to do, come back, is treat this lateral midface in the subcutaneous fat. Again, using a 22 gauge cannula. And for this one, I'm going to do an entire syringe of filler to replace lost volume in the subcutaneous depth. So this entry point is now facing horizontally, and again just into layer 2. Okay. Thanks, Max. So we've got some cannula tricks and tips. Do you want to talk us through some of these, Max, in this part of the face?
So in this part of the face, staying superficial is key. One of the easiest things to do is to not be able to see inferior cannula and dip down. And what's beneath this layer is our parotid gland. And ideally, we don't want to be adding filler into that. So if you can't clearly see the outline of your cannula, coming back towards your entry point, you don't have to come all the way out, finding your plane again, and then staying nice and superficial. Whenever you're in that subcutaneous layer as well, you will often feel some resistance, and it's very difficult to reposition your cannula without coming back towards your entry point. So if you're all the way in and you want to angle down 10, 15 degrees, that will be very challenging. So as Tristan's doing, coming all the way back, changing your direction, and then advancing again. What's tempting to do whilst you're doing that is to keep injecting filler as you come all the way back to your entry point, but then you'll end up with a concentrated area right by your entry point where you've deposited lots of filler. So have a point where you're going to stop injecting filler, which for Tristan is about there actually. Stop injecting, come back, reposition.
Yeah, so about here, I wouldn't be injecting this little part of the track every single time because, as Max said, it can create a nodular filler, which we don't want. Okay. Great. So this one, it's okay to massage, okay? We're going to create these little linear tracks under the skin, and we just want to try and flatten those, help the product spread evenly under the skin. When we're using a low viscosity and highly cohesive gel, that's very straightforward. Okay, now I'm going to take off some of the markings on this side, and it would be great to compare one side to the other. So we haven't treated the medial midface yet, we've just treated the lateral midface, creating some definition at the apex and also the preauricular. So let's take a look. Is it forwards? Great.
Very nice.
So we're starting to get this lift along the jawline in particular. This is significantly lower than the height of this over here. So we start to see this lifting effect. Head back. So now we're going to focus on the medial midface, and I'm going to do the drawings on this side to illustrate the anatomy that's relevant for that treatment. When we treat the medial midface, the first thing I always do is I just find the inferior bony margin, and that becomes the highest point of any treatment that we would do in the midface. This is the origin of our orbicularis retaining ligaments, and we can't, and we certainly shouldn't go above that margin. So anything above there is the eye, okay? We then look, with the patient looking straight ahead, we find this medial limbus of the iris. That gives us where the zygomatic cutaneous ligament will come off and insert into the prominence of the zygoma. And so this is a characteristic shape that you will see when we're looking at the two major ligaments of the midface, which have structural importance. I've already treated the suborbicularis oculi fat, which is the area living between these two ligaments, and you'll notice that this is where the apex of the cheek treatment was, okay? So what does that leave us with? Well, what happens with aging is that the fat pads that live in the subcutaneous plane start to move downwards with gravity, and also with the laxity, the elastosis of the skin. And so that starts to reveal something in this area, which is that we have a little bony ledge here. This ledge here is called the palpebromalar groove. And so even though we have restored volume in the apex of the cheek at the SOOF, we start to see this characteristic bony ledge over the lateral aspect of the under eye. This is not the tear trough, this is a specific groove that's revealed as the tissues move downwards. And we can treat this because it's something that requires additional volume. But the fat pad target here is something called the interlaminar fat, which is the fat that lives between little bands of the orbicularis retaining ligaments. And so this is an important target as an extension of a tear trough treatment to improve the under eye area. The tear trough itself in this case is the gap between this medial aspect of the orbicularis retaining ligament and this groove here, which is called the nasojugal groove. The nasojugal groove is the superior pole of this nasolabial fat pad. And so we've got a very narrow little target here, which is the tear trough, which can then extend to become this palpebro-malar groove treatment. That's how I would treat the tear trough. But remember that we generally want to be working from deep to superficial. And so there are deeper targets in the midface that I want to treat before the tear trough. And the first target is going to be the deep medial cheek fat. This is what I suspect was the intended target for the original filler treatment, because we're trying to restore some of this deep volume in the midface. The thing to just be mindful of is if you give us a really big smile, there isn't actually a lot of scope to create too much volume here, especially if that filler moves into the wrong zone. It will move on animation. So if I'm going to add volume here, it has to be deep to the muscles so that we don't have that movement on animation. What we have in the medial cheek, just like we have above the eye, we have the supraorbital and we have the infraorbital foramen. And the infraorbital foramen is obviously deep, emerging from the maxilla. The vessels from the infraorbital foramen move medially like this. And that is an important separator for two compartments down onto bone. So medial to the vessels, we have the deep piriform space. And this is a target that we can inject down onto bone. If I palpate here, I don't actually notice there's a significant degree of recession of the maxilla. So normally this would be a very good target in a deep midface sequence. In this case, I'm not convinced it will add too much value. And so I'm actually not going to treat the deep piriform space. But what I do notice is that we have this volume depletion in the deep medial cheek fat. Okay? So how do we find the deep medial cheek fat? Well, we know it's this entire area beneath the zygomatic cutaneous ligament and down on bone, just lateral to the infraorbital vessel. But this deep medial cheek fat is actually sitting beneath a muscle called the levator labii superioris, which is the roof of this fat pad. And so the best way to get into this deep fat pad compartment is to try and find a way to either get your cannula into the deepest possible plane underneath both the SMAS, layer 3, and underneath the levator labii superioris. Alternatively, we can use a needle and treat it down onto bone. In this case, I'm actually going to use a needle. And the way in which we're comfortable using a needle is because we understand the risk in this area. The major risks in the midface when it comes to the vessels are going to be the facial artery becoming the angular artery, which usually is ascending the nasolabial fold in the subcutaneous plane, and of course this deep infraorbital vessel that we mentioned previously. So considering those, if we take an injection point in line with the mid-pupillary line or even the lateral limbus of the iris down onto bone and inject slowly with a high G' product, that's how I'm going to maximize the chance of the gel sitting in this deep cheek compartment. That's ideally going to find its position beneath the lip elevator muscles and then avoid those problems of movement on facial expression. So let's clean some of this off, and then let's take a look at the injection technique. Okay, so I found my target, which is just sort of in line with the lateral limbus of the iris and slightly closer to the mid-pupillary line, certainly a safe distance away from the infraorbital foramen. And this is an entry point, an injection point which is inferior to the zygomatic cutaneous ligaments, and therefore I'm confident this would be volumizing the deep medial cheek fat. I've got my 27 gauge needle and I'm using Rejuvenation shape. Little injection now down onto bone, nice and still for me. Perfect. And we go deep. We touch down onto the maxilla. And this is where aspiration is going to be really important. Okay, so I'm happy that I'm not really tethering down any of the tissues. And I'm going to do a good 10 seconds aspiration. Okay. Happy there's no blood in the hub of the needle. And really important here that we have slow injection pressure. If we're using a high G prime product, slow injection pressure, we're minimizing the risk of filler moving along the needle track into the subcutaneous depths. I'm looking to inject 0.3 mils here.
The great thing about shape is that it's so cohesive as well, so that it will stay in that deeper plane.
Good. Thanks, Max. After injection, we can just gently mold that. But for me now, this has really improved that hollowing in the medial cheek. So let's have a look. Tip forwards. Forwards. So I hope you can appreciate here an improvement. What I noticed though is that there is another area, what we would call the deep lateral cheek fat, which I think we also need to treat.
Yeah.
Okay. Yeah. I think both of those deep compartments require volume to create the best aesthetic outcome. So let's do another injection, head back. We'll go for 0.2 mils in the deep lateral cheek fat as well. Head this way. What divides the deep medial and the deep lateral is the levator anguli oris muscle. There. So down onto bone, we aspirate again. Perfect. Sit forwards for us. Okay.
Oh, better.
And really big smile, please. We see we haven't overfilled that aspect of the cheek. Relax. Good. Now let's move to the periocular region, and I'm going to start off with the under eye. So little scratch. Well done. Thank you. So I'll show you the technique for tear trough. So we move into the subcutaneous depth. Okay, we could possibly treat in the subcutaneous depth, but I'm going to be deep this time. I'm going to move just behind the muscle. You feel a little pop here, and we're now behind the orbicularis oculi. Advancing, and you see this depth. That looks like it's subcutaneous, but it's actually underneath the muscle. And we're going to do little micro droplets of filler, being really careful not to treat this nasojugal groove. This is what will cause the appearance of an unnatural under eye. If we add volume to this groove, thinking that it's where the tear trough is, we have to be above. This groove is the floor of this treatment.
And we see this a lot where it's very tempting to overfill so it looks absolutely perfect on the day.
Yes.
And then two weeks later, once that hydroscopic hyaluronic acid has drawn all that water towards it, it then starts to look a little bit puffy.
Exactly. So we kind of aim for an 80% correction on the day. Now, when I look at this medially, I don't think there's any more volume to replace medially. And I think it's tempting to overfill it, but I love this transition here from the cheek to the lid. So I'm actually going to focus more on the palpebromalar groove. And this entry point is overlying the zygomatic arch. And again, we just have to move through the dermis. Okay. Pass through the skin and then pop through the orbicularis oculi. And now we're gliding in this interlaminar fat that exists between the lamina of the orbicularis retaining ligament. And I can create a very nice transition from the medial to the lateral under eye. Again, using micro droplets of hyaluronic acid. From here, we can also fan into the lateral aspect of the orbicularis oculi as well, underneath it.
There's this idea that you used to have to scrape along the bone and get as deep as possible with these treatments, but actually just popping underneath the muscle is the perfect layer.
I think so as well. Yeah. So, really happy with that. I'm going to do the supraorbital treatment as well before we take a look in the camera. So, this one is reducing the height of the shadow above the eye. And I'm particularly interested, I'm not interested in treating the tail of the brow, which has got beautiful support, very prominent lateral aspects of the supraorbital bone. It's the volume underneath the orbit. And to do that, we have to be very careful. Okay, so open your eyes for us. If you look upwards, you can see the depth of the shadow. So how can we reduce the height? We're going to make an entry point along the bone. This one can be a bit of a sharp one. Okay, great. And we're touching down onto bone there. Well done. Now, it would be really helpful if you could open your eye for me. Going through the skin. We need to also move through the orbicularis muscle again. There. And now, very carefully, we're going to lower the height of the shadow. This anatomical target is something called the preseptal plane, which is connective tissue just anterior to the orbital septum.
In terms of aging changes, you've also got deeper changes still into the bones. Typically the orbit, you get resorption in both an inferolateral and also where we're treating now, this superomedial area, which can enhance that so-called A-frame alongside the changes in the fat pads as well.
So if I lift the tissue up like this, you can see where the gel is sitting, and I can help to create a nice even result here. That gel is projecting downwards and reducing the hollowness above the orbits, where there's been some volume loss over the deep fat behind the muscle. This way. Look up. Okay. Can I have the cannula, please? I'm going to continue this treatment. I have to go down the lateral aspect as well, the little scratch. Touching onto bone there. Good. Just helping to blend that transition. All right, towards me. Perfect. Touch more, then we're done, okay? Look up.
And because of the vessels in this area, it's definitely somewhere you'd want to be using a cannula rather than a needle. You've got both the supraorbital and supratrochlear foramen or notch in this area.
Yeah. Good. Right, let's take a look and see where we've got to with the treatment plan. If you sit forwards for us, please. Perfect. Straight into the camera for me. Okay, so I hope you can appreciate here what we have on the patient's right side, the patient's left side, is we've restored some of the deep volume in the deep medial and the deep lateral cheek fat, also the transition from the eyelid to the cheek. The tear trough appears higher up. And we've also slightly lowered the position of the deep shadow above the orbit on this side, all in all creating a more rejuvenated side to the face. And give us a really big smile, please, without creating these appearances of overfilling. And relax. So we've decided we're going to treat the piriform fossa for two reasons. First of all, we think it will improve the volume of the medial cheek and help with the transition across the nasolabial fold. The other thing is that it will slightly elevate the upper lip, which I think is important in the lower third of this face, where I feel we've got a slightly elongated upper lip. So I'm going to talk about the injection technique for the deep piriform space with a cannula. And so let's make our entry point at the intersection between this subnasal line and the lateral canthus. So this how we find our entry points. And I'm going to use a deep projecting filler Rejuvenation shape. And we'll talk about the layers that we have to go through. So first of all, we move through the skin. We're in the subcutaneous fat. Next, we have to move through the SMAS. The SMAS is going to give some tension like this. Okay, and we have to pop. And we're looking at a deep angle, a 60-degree angle here, as we push through the SMAS. With a 22 gauge cannula, it can feel quite like you need a lot of pressure because it's more blunt. But we are using a 22 gauge to improve control of depth and safety. Okay. If it doesn't go through easily, we can use a twisting motion. There. Okay, so I'm through the SMAS of the midface. There is, however, another muscle we have to move past, which is the LLS muscle. This one sits on top of the deep medial cheek fat, and we'll navigate that by keeping a deep angle as we progress through the medial cheek. Once we are behind the LLS muscle, there. Now we're gliding very smoothly, and this will be probably the deep medial cheek fat that I'm in. If I progress even further, I find a bony target. That's my deep piriform space. And here, I'm going to be injecting whilst moving a little bit.
There's branches of the infraorbital nerve that run through here, so it can be a little bit uncomfortable, and you have that slight nervy pain. You'll often see your patient flinch a little bit when you're in the right space, but that local anaesthetic quickly makes it feel more comfortable. But worth warning your patients afterwards that if their top lip feels a bit numb afterwards, that's completely normal and only tends to last 20-30 minutes or so. We also know from our ultrasound examination beforehand that the facial artery is lying more superficially in this area and actually more lateral. So that doesn't mean that there's no vascular risk here, but it's significantly lower.
Great, almost done here, Emily. You're doing great. Done. Fantastic. And I always like to feel here, I can feel a deep nodule of hyaluronic acid right in the deep piriform space. And we can definitely massage this like that if we want to encourage a bit more of a smooth result. Okay, this I think really completes the medial cheek. So let's take a look at how that looks. It's flatter. Yeah. There's less contours of the light and the shadow now.
Yeah.
Everything feels like it's positioned in the most natural possible way.
I'd even say the corner of the mouth on that left-hand side is just being pulled up a little bit more compared to the right-hand side, or certainly the lateral part of the upper lip.
Okay, the final thing we want to do, just to really balance the aesthetic in this result, is we want to try and increase the height of the lip. And in doing so, I think we will rejuvenate the perioral zone. We can also treat some of these vertical perioral lines. What we're trying to avoid is too much projection and overfilling of these lips. A very natural shape to the lips, and the patient has very kind of slight, delicate features. And so a significant volume in the lips won't look appropriate, but we can start to target some of these age-related changes. And so to do that, we're going to do a little bit of vertical height with a tenting technique in the lip, and we're also going to try and reduce the dermal creases with some hyaluronic acid as well. So now let's look at a vertical tenting technique for the lip. We're going to start off at the GK point, trying to create as much height as we can at the Cupid's bow, okay? So chin up for me, thank you. We're just going to, with the bevel facing upwards or forwards, we're going to track down like this. That's the depth you want to be, okay? So just underneath the skin. And that would be one linear thread.
And this technique respects the compartments of the lip because we are staying within the compartment when we come in at this angle rather than traversing them and disrupting that fibrous tissue between them. Always staying within the white roll of the vermilion border still.
Sometimes if the filler tracks superficially like this, we don't have to worry, we can massage it. And it will integrate into the tissue. We see on the day that this border becomes slightly inflamed, but it's not to be mistaken with treating the vermilion border itself. I think that would be all we would do on this side. Mm-hmm. So let's take a look now, and we can see the vertical height that we can achieve from this approach, which is elevated the left lip. And you can see that in combination with the mid-face treatment sequence and the peri-orbital treatment sequence, we've got a really nice rejuvenation.
Hello, my name's Jo. I am a doctor with a background in anaesthetics. I now work full-time in aesthetics, and I'm using some transferable skills between my old career and my new career today. We've introduced ultrasound into the Academy Clinic. So I work as a trainer here at Harley Academy. I'm also head of medical services for the Academy Clinic. I'm here today helping Tristan out.
Perfect, thanks Jo. Let's take a look at the scans now. So if you remember, we've been looking at, particularly with this case, focusing on ensuring that the filler ends up in the target that we intend so that we avoid these mid-facial overfilling risks.
Let's start a bit more laterally. So we've got that nice bright white hyperechoic line of our zygoma. And then we're heading into the maxilla here in the mid-face. So we've got some superficial subcutaneous tissue here with some little interfascial lamina that you can see in the fat. As we move a little more medial, I'm going to change from an axial probe in a second to longitudinal, but you can see we've got some deep filler deposits, those hypoechoic spherical filler deposits to the left of the screen.
So that would be the apex of the cheek injection?
Those are our cheek apex injections.
Can you see if it's on bone?
Yeah, it's just above the hyperechoic structure of the maxilla. And then if we rotate our plane, so we are now longitudinal, we are going to be looking down, so let's get a little bit more jelly. So we're looking down, the little black bit at the top left of the screen is the inferior portion of the orbicularis oculi. And then as we move a little more inferior, We have our LL SAM, which is another thick black muscular structure, and a branch of one of the other lip elevators. Let me just get a better image. Just branching off above it, and you can see underneath that medial muscle, we've got hypoechoic hyaluronic acid filler deposits. Some pre-existing, so the one a little bit more inferior is the pre-existing filler, and the one just above that, to the left of the screen, is our newly placed filler, down just above the bone that you can see. That's the bright white line.
So can we get a shot of just the best shot of the black filler and the white line of the bone? I think that's what we need to, I really want to see that.
Sorry, Emma.
That was good.
Yeah, that was good. There's a slight lag on it because it's running out of battery.
Should I increase the depth slightly?
Sorry? Yeah.
There we go, good. That's what we want to see. So one of the things we're learning about injectables is that where we thought we were injecting is not often where the filler ends up. And there's various things we can do when we're injecting to make sure that the filler ends up in the place we intend. And this case has been really important in showing previously where filler has been injected badly, dissolving that filler, and then choosing specific targets and noticing that you don't need an ultrasound scan to actually make sure you're in those correct targets during injection, but the scan is helpful to show and confirm that we're in the right place. So in this case, for example, demonstrating that we are injecting down onto the maxillary bone when we're treating the deep medial cheek fat or the piriform space. And because they sit beneath the muscles of facial expression and the elevators of the lip, when the patient smiles, we don't get this bulging projection, and that's crucial for understanding how to create natural results for our patients. So after we've created this vertical height in the left upper lip, which I think if you just look into the camera for us and head off, you can really start to see the improved height. If you blow a kiss for us, we still have these vertical lines. And the reason we have those lines is because the dermis is actually very attached to the underlying muscle in this part of the face. So I'm going to use a cannula and I'm going to disconnect the dermis from the muscle. And in the process, add a very thin sheet of hyaluronic acid, which should reduce the perioral lines. So making my entry point. Well done. Okay. This can just create some inflammation and swelling in the upper lip post-treatment. So your patient may worry that they've had a bit of filler beyond the lip border, and you just have to reassure them that this is just temporary swelling. But as I'm pushing through, I can feel the little attachments. And the objective here is, before injecting, to subsize and disconnect the dermis from the orbicularis oris muscle. Can be a little bit sore, so I'm going to inject a little bit now with product. I'm using Rejuvenation Revise here, which is the softest product, still a cross-linked gel, to try and reduce the discomfort and also create a bit of space.
And you can liken this to like a blunt dissection, can't you? And then a bit of hydrodissection when you're advancing with some product.
So now there's some gel in there. It's more comfortable. I'm going to just be a bit more fast with my dissection. Okay, so one last treatment I'm going to do before we review the entire treatment sequence is I'm going to add a little bit of volume in the posterior aspect. And I notice here that there's a little bit of skin laxity and there's a very small amount of subcutaneous projection and tissue. I've previously treated the preauricular area, but in order to really get the best benefit along the jawline, I'm going to treat the mandibular angle in the subcutaneous depth. And ordinarily, this would have been something I did at the start of the treatment sequence, but I've just noticed that this is something that's going to enhance the results at the end of the treatment sequence. So if you can rest your head back for me, turn all the way this way. And so this one is a relatively straightforward injection. We have to follow the same precautionary principles that we have when we're treating the preauricular area in general, which is that we want to be in layer 2 and we want to stay in layer 2. Okay. So with this, we can start to sculpt the posterior aspect of the jawline. A little bit of resistance here as we move through different fibrous septa in the tissue, but that's our subcutaneous depth that we want to treat into. Conscious here that I'm using a highly projecting filler, so I don't want to inject too close to the dermis, and it's really important to understand that you can be in layer 2 scraping the underside of the dermis, and you can be in layer 2 deeper in the subcutaneous fat. And when you're using a really high projecting gel, you want to avoid being that close to the dermis because you can create tracks under the skin that actually don't disappear on massage. And when the patient opens their jaw, you don't want to create tracks just within the skin. And so I'm going to be in the midpoint of layer 2 when I'm injecting in this area.
The structures we're thinking about here, we've got the masseter muscle, parotid gland a little more superiorly, cranially, and then we've got our facial artery emerging deep.
Yes.
Very broad of the masseter muscle.
So would we say this one is a relatively low risk
If
injection?
you're in the right depth, yes.
Yes. And that's why this would be regarded as a development stage 1 technique. So it's suitable for beginner injectors. That's it. And we just got to give it a firm, if you bite your teeth together, we can just massage down against the muscle. Okay, perfect. So now let's take one last review. If you look into the camera for us. So if you remember, this is Emily, and we have started off by dissolving filler that was in the wrong depth. And then we did a treatment sequence today that started with the cheek apex and the lateral zygoma and treating the preauricular and this kind of subzygomatic region as well. You can see this beautiful definition along the cheekbone, giving it this kind of feminine, natural contour along the cheekbone itself. Then we moved to the medial cheek, being really careful to inject beneath the lip elevators with a needle, treating the deep medial and the deep lateral cheek fat. And then transitioning to the periocular region, treating the tear trough itself, and then the palpebromalar groove, and then supraorbital, treating the A-frame to lower the depth of the shadow above the eye. Then we did an additional Piriform fossa treatment because we noted that actually this was something that could directly improve the upper lip by elevating the upper lip slightly. And that also really nicely improved the transitions and the shadows through the medial cheek. I've treated just this side of the lip, and so you can see the height of this lip using a tenting technique. And if you blow a kiss now for us, hopefully you can see a reduction in the perioral lines as well, as we've used some product and a cannula to dissect those attachments. Just blow a kiss again. I think that's a very nice example of that. Generally, you can see, because we volumized here, there's a lot more stability to the muscles. If you smile for us, really big smile. We don't have any symptoms of overfilling because we're injecting beneath the lip elevators. Final injection, if you relax, was to create some support and structure in the lateral aspects of the jawline, which I hope you can appreciate is now a higher and more rejuvenated jawline on this side. So in total, a multi-mil treatment. I'm going to do the full treatment now on this side, and then we'll take a look at the final results on camera. Okay, so this is Emily after the full face treatment plan, the lateral and medial midface around the eyes and around the mouth. We've shown on the scan that we have replaced the filler which was previously in the wrong depth, which is now in the correct depth. And this is immediately after treatment, so there's going to be a little bit of swelling, particularly around the mouth. Okay, let's do some expressions. So look into the camera for us, okay? And now, can you smile? Okay, and relax. Turn this way, and smile, and relax. So that's a really important angle to appreciate the change in the volume in the midface when the treatments are in the right depth. The thing that I'm noticing the most is the transitions here from the lateral midface all the way through to the lips, and where we don't have these waves in lights and shadows, particularly the deep support in the anterior midface is what's giving that very rejuvenated appearance. What we don't want to do is the temptation is to create this volume that's so high up on the cheek to simulate what a very youthful, kind of almost early 20s type cheek appearance is, because we have to appreciate the difference between youth and beauty, and we can still retain beauty over the decades without trying to simulate what youth always is like. And with the combination of skin laxity and volume loss, we will naturally have these changes, and what we can do is reposition tissues in the most natural way. So this is the second part in the treatment plan. How do you feel, Emily?
I feel good. I feel great.
Good. Do you have a mirror? Let's do it. Emily wants to see you. Yeah, that's fine. Have a look in there and tell us what you notice.
It's great. It's really nice. It's really nice.
What's the thing you notice the most?
The kind of smooth line across here.
Mm-hmm.
Here.
Above the eye?
It's amazing.
Yeah, okay, great.
And certainly got rid of those horrible lines. That, I mean, I know that's going to go down, but that looks really smooth as well. It looks good. It looks good.
Good.
Yeah.
All right. So we're going to get you back in a few weeks for a final review.
Okay.
But thank you for today.
Thank you very much. Thank you.
Right.
Thanks all of you.
Thank you.
Thank you. Okay, so we're back in clinic with Emily after her filler treatments. Let's have a chat with Emily and see how you felt after treatment. Can you just give me some honest feedback about, I would say, the treatment itself?
Yep.
And then also your experience in the following 1 or 2 weeks after the filler injections that we did.
Sure. So I was surprised at how much it didn't hurt when you were doing the treatment, actually.
Okay.
Which was
Good.
Good. Post the treatment, I had nothing major in terms of any reaction. I had a small amount of yellowing, a bruising, but it was not significant, and it was quite easy to cover up with a bit of foundation, kind of day 2 onwards. And I'm very pleased with the jawline. There's definitely been some lift here and more definition here. I'm really pleased with around here. I think it looks really natural. I still think there's work to be done around here to give a little bit more lift here. Really, really happy with the, I don't know the word, but the...
Above the brow?
Yes, the brow.
Above the orbit, yeah.
And the lips, I'm happy with as well.
Okay.
So just, a few lines here, but the actual lips I'm really pleased with.
Okay, amazing, thank you. So if you remember, in this case, we previously dissolved some historical filler that's built up over 10 years. We used an ultrasound, we showed where the filler was in the wrong places. We've re-injected and scanned and shown that the filler is now in the right deep compartments that we wanted it to go into. And so then this is the follow-up after quite a significant filler treatment. Let's have a look on this camera now, if you can zoom in here for me. So I can see here that we are getting closer to the final results that we're looking for. The main thing to appreciate is that we don't have any overfilling, particularly in the under eyes or the lips. I think this additional height in the upper lip is really effective at rejuvenating the lips. And I definitely see that we've improved along the jawline and started to lift with this volumizing treatment. And again, in the upper aspect of the eye, we've lowered the depth of that hollowing with a little filler injection. That's an A-frame treatment which rejuvenates around the eye. I agree with what Emily's saying in terms of priorities. I think that we still see some laxity in the skin. We still see some creases in the upper lip. And I think the objective now is to start thinking about how we can improve the skin. And for that treatment, we're going to be looking at biostimulators. Biostimulators are not the same as what we've used before, hyaluronic acid volumizing injections. A biostimulator specifically targets the skin by stimulating the fibroblasts, and we get a upregulation, we get a deposition of type 1 collagen, and in the process, we get thicker skin, we also get tighter skin. And the objective today is to try and improve the quality of the skin and also the tightness, particularly in the lower face. And I think it would be really great to show how a combination of volumizing fillers and biostimulators can get the best kind of results. So I'm going to show you a treatment plan today which combines the use of biostimulators on the top of what we've previously done with normal fillers. Sound good?
Sounds great.
All right.
Really good.
Okay, so let's get this product ready. This is the Alonze, this is the biostimulator. And we're going to mix this with 0.2 mils of lidocaine. And the reason we do that is because the product itself doesn't contain any lidocaine, and we want to improve the level of pain for the patient, but also adding a little bit of lidocaine gives us a bit more volume to be injecting, makes it a little bit more easy to get the product into the subdermal plane that we're trying to inject. So after a few of these pushes, you can see how we can mix our products. This is also how we would be mixing lidocaine into any product that we might want to use, or even combining different products generally. So once we've done that, we're always going to use a 22 gauge cannula when we're injecting in this way with a biostimulator. The main reason for that is we want to minimize the risk of injecting intravascularly. So I've got a 22 gauge cannula here, and really important as well is we've done a really in-depth skin decontamination, and we want to make sure that there is as much of a sterile field as possible when we're injecting with biostimulators. Taking a look at where Emily could most benefit from a biostimulator, if we look at the crepiness, you can see the skin generally here has lost some collagen, it's lost some elastic fibers, and this is a consequence of the natural aging process. It's also photo damage and various external factors that can affect the dermis of the skin. So by stimulating the fibroblasts and improving the collagen, the type 1 collagen in the skin, not only do we create tightening and contraction of the dermis, but we also increase the volume of the dermis. And in doing so, we're going to get more youthful looking and tighter skin. And so I can see that I want to create some biostimulation in this direction. And so fanning a cannula all the way up to even into the subcutaneous plane in the temple is going to allow me to achieve this. But I also want to cross over this marionette fold to try and reduce some of the tethering of the ligaments and try and create as much of a nice transition from the jawline through to the chin. So I'm going to fan in this direction, but I'm also then going to fan in this direction with a cannula. And we're using here a 22 gauge cannula, and the reason for this is that we want to minimize the risk of any intravascular complications. And the larger the cannula, the lower the risk of the cannula being sited inside a blood vessel. That's particularly important when we're using biostimulatory products, because we're not able to actually dissolve or reverse the biostimulator. And so, yes, we're injecting in a plane where we don't think there's going to be any major blood vessels, but at the same time, we want to inject in the safest possible way. And so you can see this is the depth, this is the subcutaneous plane. And if the first rule is to minimize the risk of any intravascular product, the second is to avoid nodules. And using a biostimulator has a risk of nodules because we're injecting a very active stimulator next to these fibroblasts. And so if we concentrate the product in any singular area, the patient could feel lumps under the skin. And so you'll notice when I'm injecting, I'm just creating as much even spread as possible of the biostimulators without much overlap and without concentrating the product in any single area. I'm also injecting in the direction that I want to achieve the stimulation, and that means I'm going all the way up towards the zygomatic arch and even actually sometimes into the temple as well. This little bit of resistance here is little fibrous septations within the subcutaneous plane, and it's worth understanding that we're not just stimulating the dermis of the skin here. The entire subcutaneous plane has a huge amount of collagen bundles throughout it as these little divisions throughout the subcutaneous plane that I'm moving through here all kind of create a subcutaneous network of collagen fibers and fat. And so as we stimulate the skin, we're also stimulating the subcutaneous fat tissue, and the compartments that divide those fat pads are all tightening and all contracting, and all of that contributes to the aesthetic result you see after treating with a biostimulator. How are you doing here, Emily?
I'm great, thank you.
Okay, just keep breathing. Yoga breathing.
And exactly.
Sit forwards for us, Emily. Let's get this on camera now. I just want to see this. Not that it has much particular clinical relevance, but I just want to show what it looks like before and after. So this is immediately after the biostimulator treatment, and a lot of what you see in this immediately afterwards is just the fact that I've injected volume. It's not, of course, we're not seeing here the benefit of the stimulation yet, but you can see the areas that I've targeted with the biostimulator. And what we'll do is we'll come back in a few weeks' time and we'll see how the biostimulator has taken effect, and we can take some final photos as well.
What we learned in aesthetic medicine even 1 or 2 years ago is now outdated. Why? Because aesthetics is still a relatively new science, and the research underpinning our work, particularly our understanding of anatomy, has advanced significantly. Hello, I'm Dr. Tristan Mehta, founder and CEO of Harley Academy, and I want to introduce you to GEM, the Global Evidence Matrix. GEM is a dynamic, evidence-based framework that gives injectors a clear, consistent guide for safe, effective treatments, all grounded in science, not in corporate sales pitches. GEM combines clinical research, anatomical knowledge, and injector expertise, and it's always updated with the latest evidence. Think of GEM as your interactive map for facial aesthetics, guiding you through every step from technique to product choice. With GEM, you're not just injecting, you're working at the forefront of medical aesthetics. Join us in setting a new standard for safety and results.
Welcome back to our clinic at Harley Academy, and I'm really happy to have Emily back for her final checkup after quite an extensive treatment plan. So let's try and recap together the journey so far. So you joined us at the start of this about 6 months ago, I would say, and Emily was very open-minded about the treatments that we could go through. And if you don't mind me saying, you're also kind of going through some difficult life challenges, and everything was changing for you. And so we had a look, and what we saw was that there was lots of historical treatments that were done. We looked on an ultrasound scan, targeted dissolving of different previous filler in different compartments, some of them too superficial. And then Emily lost a lot of that volume, and over the last few treatments we've replaced volume in a very structured way, as you can see in the video. We've also used a biostimulator, and then since then Emily's also had some toxin and profilo, so the full works over the last 6 months. But what I'm really interested to hear is your honest feedback, because people are watching are going to be interested in the journey that you've been through.
Sure.
And they might be in your shoes and thinking about treatments. So yeah, please tell us.
Well, number one, it was a bit of a shock when you dissolved it all, because I'm so used to having the filler, and it had been there, I think we worked out, at least 10 years. What has been lovely is I really feel like it's kind of been a bit of a canvas that you've worked on, and you've consulted with your colleagues, and you've really thought about all the treatments that you offer or that you have available to you, like the toolkit, if you like. And you've kind of really explored what was available to give me the best possible results. I'm thrilled with, there was a very, it wasn't massive, but it was subtle with the tear troughs. I'm thrilled with the cheekbones and just in the temples. I think this is really, I'm really happy with that. I also am really happy you've definitely lifted the jawbone. So overall, I'm honestly very, very pleased. And I appreciate how you've managed me as well. I think that's part of it as well as a client, and I really appreciate that.
And we'll just do a final review of Emily. For me, Emily has a really kind of elegant face, beautiful bone structure, looking very, very natural. And a lot of the areas that we've treated now, for me, have completely settled. A lot of that biostimulation is continuing to work in creating tightness across the mid-face. You'll notice some of the more subtle areas of refinement, like the upper eye and the upper lip that's been treated. And if you give us a really big smile, you can see that she's not overfilled. She's looking very natural on expression and relax. And at rest, you see this natural flattening in the anterior mid-face, which for me isn't something that I want to additionally treat. I think this shot, you can see here very clearly, Emily's a very beautiful face. The thing that concerns her ongoing is this little shadow here, and it's tempting to try and soften this, because previously there was a lot of filler up here which was bunching it backwards. And whilst I appreciate that's possible, in this case it's just a really important learning point that it's not going to be possible to add more volume to reduce this shadow, because she would look overfilled. It's also not a good shadow nasolabial fold to treat directly with filler, and so this is one of those facial aging features that are part of Emily, and it's not something that we necessarily can or want to reduce. If it was something that was of ongoing concern, then we could look at skin tightening to try and lift the shadow this way. But for me, I think Emily's looking fantastic. So thank you again for being part of that. Is there anything you want to say to people that might be watching who have or looking at going through this kind of experience? Anything you want to share?
I would say I think it's useful to do your own research in terms of the products, and obviously there's loads of information out there online, so that you're coming with some information. I think be realistic in terms of your expectations. I'm 53. I shouldn't want to look 23. So I think, coming with realistic expectations. But probably the biggest thing for me would be to trust you guys, and trust that you come with, mountains of experience of treating patients and the products that you're using, and knowing what they can achieve. Perfect.
That was exactly what we try and share to our patients, and like I said, a really good journey. So thank you so much again.
Thank you.
And
thank you.
Hope you've enjoyed this video, everyone. If you want to follow up with Emily's journey or see more content like these kind of full feature, full treatment plans, then you can continue to subscribe to the channel, because we're going to be publishing these every month. So thank you for your time, everyone, and we'll see you next time.